Welcome back, friends. Now let's look into another group of disorder which are known as primary headaches, where we don't have a direct etiology per se like secondary headache, and there are always a problem headache for us because it's very difficult to solve the problem of this patient of primary headache. But in our society that we live in, very often people have got a different kind of remedies, to get rid of all kind of headache that they face with. Now the very first one is the headache that we should know about is the tension headache. The tension headache. In the tension headache, do remember this, that it is something which is more frequently seen in the females than the males. So one of the most common primary headache that we find is our tension headache. So the most common primary headache that we find is the tension headache, and it's more frequently seen in females than males. Third point here is that this is something which is often associated with depression. Apart from this, although the name is given as tension headache, but tension is not an etiology at all for this problem. Tension is not an etiology at all for this trouble. But still, why is it named as tension headache? For the reason because there is a kind of a tension which is felt in the patient's head. So the pain which is felt by the patient is often a dull aching pain with a typical band-like sensation on the head region. So if I can understand this all into a diagram, it's like this. So my patient will complain of a typical band-like sensation on the head region that will extend from the frontal till the back. And there's a lot of contraction of the muscles or the tension in the muscles in the scalp region that is seen in these patients. So that's why the word tension comes here, okay? And of course the patient is not very happy, they're depressed, right? Apart from this, these patients, you should know this, that they don't have nausea as a common complaint, neither do they have photophobia with them, which is a very common accompaniment in patients with migraine. So two things happen to be totally missing in them. One is nausea complaint and second is photophobia. As far as the treatment part is concerned, maybe an acute attack which I see as, that means an attack which is acute in stage. Just now my patient started complaining of a pain which is of tension headache. Then in that case I can use the drug like ibuprofen. An NSAID like ibuprofen could be the treatment. But to prevent such a kind of a headache that we know as prophylaxis, we can use in these patients drugs which can kind of treat the depression element also, and can be a type of drug which could also relieve the pain further on. That is your amitriptyline. The amitriptyline. Amitriptyline is a drug that is a tricyclic antidepressant, we all know. To prevent the recurrent attacks of tension headache, we often use this drug in most of the patients. Now, tension headache is something that is on regular basis the patient has got. So maybe if the headache is there for more than 15 days in a month, like a chronic headache. So if at all the headache is chronic, that means almost more than 15 days in a month, then in that case we require prophylaxis for tension headache in form of a tricyclic antidepressant, that's amitriptyline. Okay. Now let's see, most important of all headaches that we find is migraine. First, the epidemiology part again. Migraine is something which is more frequently seen in females than males. Okay. Apart from this, to diagnose a patient migraine, there's a perfect diagnostic criteria being laid down for this. So there's a perfect diagnostic criteria to diagnose a patient with migraine. Here the first thing is regarding the duration. How long will the headache last for? Duration part. In the duration we find it to be somewhere between 4 to 72 hours. So more than 4 and less than 72 hours in most of the patients. Apart from this, the quality is also equally important. In the quality, we have got a mnemonic which is PUMA. P stands for the pulsatile nature of the headache. Very often patients with migraine are complaining of a throbbing pain which is pulsatile. U stands for unilateral. That means it happens only on one side or not on both the sides. So it's only on one side of hemicrania, unilateral presentation. M stands for moderate to severe in intensity. Moderate to severe in intensity. So my patient with a migraine attack will complain that the headache that they are having is not letting them go to work today, or it's very bad that they cannot come out of bed today. So maybe they are bedbound or workbound kind of people. The last thing that we find is aggravation on movement. So when the person moves the head part or maybe the body itself, so it increases on movement, aggravation. Now do remember this, that out of all in the PUMA constellation that we find for migraine diagnosis, 2 or more than 2 are sufficient. So not all 4 of them need to be present. 2 or more than 2 symptoms are sufficient enough to call it as a case of migraine. Apart from this, any one of them, any one of either nausea or vomiting, photophobia, phonophobia. So out of the 4, we find that either one of them is sufficient enough along with the PUMA constellation to diagnose a case of migraine. Now remember this, out of all the things that are in anyone, the most common is nausea. So it's taken like this: a female patient comes to me with a unilateral throbbing headache with nausea, is nothing but a case of migraine, right? If it is dull aching, band-like sensation in a female patient, we think about the tension headache. Apart from this, we should know something extra about it, that how do we classify migraine, the classification part. So in the classification part of migraine, do remember this, that the migraine is classified on the basis of aura. Aura we have discussed in detail in the seizure disorder chapter. It means a kind of a hallucination that the person perceives. So most of the patients of migraine that we come across with have got a visual aura, and few of them can also have a sensory aura also. So most common aura, if you see in patients of migraine, is seen as the visual aura. Now how do we classify based on this? If my patient has got an aura which is like visual aura, or maybe if the patient hasn't got it. So if my patient has got an aura or maybe a hallucination which is visual prior to the PUMA constellation or headache to happen, that kind of a migraine is known as a classical migraine. The other one is not known as unclassical or Western. It is known as a common migraine. Common migraine. Why is it known as common? For the reason that 80% of patients with migraine don't have aura prior to the onset of headache, while just 20% of them are going to have it. So we find that the migraine which is more common is a migraine that is not preceded by aura, and that's known as a common migraine for us. Apart from this, there is another migraine that we all should know about. That's the acephalgic migraine. Acephalgic migraine. Now find this name out, it's very simple. There is a patient of migraine without cephalgia. That's the word A absent, cephalgia in them. Now if you understand the word cephalgia, ceph means head, algia means pain. So this patient doesn't have headache of migraine at all. But why are they coming into this group of migraine? Because these patients have the typical aura of migraine that we find. So a migraine that just stops on the face of aura and no headache happens in that patient has been referred as the word asymphalgic migraine. Okay. Apart from this, there are other group of migraines that we all should know about. For example, ophthalmoplegic migraine. Ophthalmoplegic migraine. This is a topic that you'll come across in opthal also. Now these patients are defined like this. This is a patient of migraine with a throbbing unilateral headache, right? But on the side of the unilateral throbbing headache, my patient suffers with a partial, recoverable third cranial nerve palsy. So on the side of headache, we find that the person suffers with a third nerve palsy, which is not complete but partial, and with the headache it subsides also, it's recoverable. And I want to write this also, it's plus minus fourth and the sixth nerve also. So the common nerve which is involved in migraine patient is third. Fourth and sixth involvement could also happen, that's why I'm writing the plus and minus over there. Okay, but the typical definition goes with the third only. Apart from this, there is a migraine which is known as the basilar migraine. Basilar migraine. It's also known as Bickerstaff migraine. Bickerstaff migraine. Something into the latest classification, they have included this one as migraine with brainstem aura. With brainstem aura. Okay, so there are various names given to it. The older name that we have got, the oldest actually was a Bickerstaff migraine. Then the name came as basilar migraine. And now something that we have included in the recent classification, the newest name maybe, is the migraine with brainstem aura. Now you'll understand this. So if you remember, the posterior circulation was formed by the two vertebral joining to become basilar, and then the PCA, and that happens to be the major blood supply of our brainstem also. So now there is a migraine attack in that particular zone. So those arteries like the basilar or the PCA are involved. So what are the symptoms that we find in the patient? These patients are going to have brainstem symptoms. For example, they're going to have ataxia. They're going to have giddiness, vertigo. They can also suffer with dysarthria also. Right? So these brainstem symptoms could be seen. Along with this, they might also come with blindness because of the occipital lobe involvement that goes with the PCA, right? Now, I've included this term, migraine with the brainstem aura. So there are symptoms that precede migraine, headache, and those symptoms are the brainstem symptoms, or maybe the symptoms of the posterior circulation. The basilar artery is a part of the posterior circulation. Now followed by this, we have the headache now. So look at this patient now. This patient had symptoms of aura which were around the brainstem region, localized, followed by headache. And most of these patients after the headache lose consciousness also, and they recover also. So there are symptoms that are migraine symptoms, aura symptoms, which are related to the brainstem area, then blindness, headache, loss of consciousness, and then of complete recovery. Just one more point to add over here, that these patients have got family history of migraine. So people with family history of migraine can have a migraine of a different type known as the basilar migraine or the migraine with the brainstem aura. Okay. One more thing is this, some of the patients with migraine can again have a family history. So those patients are known as familial hemiplegic migraine. Familial hemiplegic migraine, also abbreviated as the term FHF. So there are three types of FHF that we know: familial hemiplegic migraine type 1, familial hemiplegic migraine type 2, and familial hemiplegic migraine, oh sorry, it's M not F. Familial hemiplegic migraine type 1, type 2 and type 3. Okay, this is something as a topic I always remember because many questions have come on it and most of them are memory based, so don't panic on this. So there is a defect somewhere in FHM type 1 since it's a family history going on, so there has to be some gene and some problem related to this. So it is a problem on this gene known as CACN1A gene. So there is a mutation on this particular gene CACN1A gene. Now this particular gene is somewhere regulating the calcium channels which are of the type PQ. So there is a mutation and there is a problem on the PQ type of calcium channels. We'll read about this in myasthenia also, or LEMS, that these channels are important for the calcium inflow into the nerve and release of acetylcholine. So maybe because of this gene problem and this channel problem, these patients are unable to release out acetylcholine from the nerve and they suffer with some kind of a weakness. Okay. Apart from this, there is another one, that is the sodium potassium ATPase. So there is a gene for that also, and a mutation on that gene is going to relate itself to the familial hemiplegic migraine type 2. Familial hemiplegic type 3 is a mutation in the SCN1A gene. SCN1A gene is another gene which is nothing but the voltage gated sodium channels. It is helpful for that. So there is a problem or mutation on this gene, and the voltage gated sodium channel defect is seen in them. So in all the three things, we remember one thing out, that there is a problem in muscle contraction, and because of that the person suffers with weakness, hemiplegia, right? Now just for epidemiological interest, 50% of patients with FHM are FHM type 1, that's more commonly seen, while 20% are FHM type 2. So again, this is something which I see more like a memory based topic. Okay, not too many explanations given why and what happens here, but certain genes that we need to remember to cause this problem. Okay, now what is the main reason for having migraine, or maybe the most accepted theory for migraine attack to happen? The most accepted theory for migraine patients. So when we go in for the most accepted theory for the migraine patient, it is known as the cortical spreading depression. There are a lot of theories which have come before that, but out of all, the most accepted theory is a cortical spreading depression that we find in these patients. Now in the cortical spreading depression, do remember this, that there is always a trigger to cause migraine. That means a migraine starts with a reason, trigger. There are a lot of triggers for migraine. I'm telling you the common ones. First is hunger or fasting. If the person is fasting for a very long time, they're going to have migraine. Second, lack of sleep, insomnia. Again, a very important trigger for migraine. Apart from this, of course, something more important, stress. That's again a trigger for migraine. And looking at the food items, we have got as a trigger for migraine chocolate, cheese, and something that may be out of our pocket, red wine also. Some of the people have included coffee also as a trigger for migraine, but again it remains to some extent controversial. But fasting, insomnia, stress, chocolate, cheese, red wine, these are the common ones. And of course in females, one thing to add, menses or menstruation is another trigger for migraine that we know. Now what happens is, whenever you have a trigger for migraine, there is a sensory input going on to the fifth or the trigeminal nerve. There is a sensory input going on to the fifth or the trigeminal nerve every time. And especially the division which is active over here is the ophthalmic division. Ophthalmic division, the V1 division, okay, of the fifth or the trigeminal nerve. Now what happens is that once the fifth nerve gets activated, the signal has to go to the brain. Now remember, the sensory gateway is still one place, what? Thalamus. So there is a track which connects the fifth nerve with the thalamus. And we know this track by a nice name. It's the cognitothalamic track, or a cognitothalamic pathway. Just make some correction in the spelling. Cognitothalamic pathway, right? Once this pathway gets activated, in my patient, there is going to be release of something which are known as the vasoactive peptide. So in our patient, there is going to be release of vasoactive peptides. For example, one of the chief here is CGRP, and I'm very sure you will be well versed with the full form of this CGRP. It's calcitonin gene related peptide, CGRP. Apart from this, there are other substance also, the famous substance which you know as the substance P, okay, and of course the vasoactive intestinal peptide, or the VIP, very VIP person, and a big no. Big no stands for the nitric oxide. Now if you know these vasoactive peptide, what do they do? Most of them end up doing what? Vasodilatation. So there is vasodilatation of the vessels now happening. Now this kind of a vasodilatation typically may start in the zone in the back part, that is in the brain, in the occipital zone. So just imagine, in the occipital lobe of the brain, there is sudden vasodilatation of vessels. So whatever field of vision I am seeing, it's fine. Now suddenly I'm going to see a lot of flashes of light because of that. So now what happens, that the whole thing gets add on, it's fortified now. So instead of seeing everything normal in front of me, I'll see some flashes of light because of hyperemia in the occipital lobe. And why did it come? Because of vasodilatation. So in our patient, we are going to have flashes of light being seen. Flashes of light. Now this flashes of light is seen more like a positive symptom. Positive symptom, why? So it's something added on, no? It's positive symptom that we find. Sooner this very vessel will now undergo vasoconstriction, the same vessel. After vasodilatation, we are going to see vasoconstriction of the vessel now coming in. Now since it's an occipital vessel that I relate to, now initially there was hyperemia, vasodilatation, positive symptom, flashes of light. Now less blood will come. So what will happen now? Darkness will happen, or maybe scotoma would be happening in my patient, which I can regard as a negative symptom now. Now once the flashes of light are seen or vasodilatation happen, I know it's the nature of the vessel itself. On the vasodilated segment, there is going to be sudden leakage of certain proteins, plasma protein, you know. Sudden leakage of plasma is going to happen at the site of vasodilated vessel, right? Now that leakage of plasma and all is going to cause meningeal irritation in the surrounding meningeal lining. Once that happens, that is enough to cause what we know as pain in our patient. So I have taken this down because something they need to understand. The pain in migraine patient happens due to meningeal irritation. So if the meninges are irritated, so whenever I move the head, I move my body, I move the meningeal covering maybe, that's why the pain often aggravates on movement in these patients. Okay. Now this whole concept is known as cortical spreading depression. Why? Because this vasodilation, vasoconstriction and all keeps on moving across the cortex at the speed of 2 to 4 mm per minute. So there is a wave of depression maybe which keeps on spreading across the cortex at the speed of 2 to 4 mm per minute. So it is spreading across the cortical spreading depression. So let me just summarize again. There is a trigger, there is an input coming to the fifth nerve, then the corticothalamic pathway gets activated and the release of vasoactive peptides happen. Okay, see on the way there are descending pain modulating things also, like your locus coeruleus in pons, dorsal raphe nucleus and all. So they try to modulate the pain, but I'm not that much concerned about them because I'm more concerned about why does pain happen in patients of migraine. The best explanation comes from this. The spread of the wave happens at the rate of 2 to 4 mm per minute. Cortical spreading depression. Okay. Now apart from this, we should know something more than this, that how would you go in for treatment of patients of migraine. In the treatment of migraine, there are two things which I understand. One is the acute attack. When my patient has come with an acute pain, a pain of migraine which is unilateral throbbing kind of a pain. Now remember this, in migraine patients when we consider for the acute attack pain, one drug that we still use are the serotonergic agents. Serotonergic agents. Okay. Why do we give a serotonergic agent? Because if you know the nature of serotonin, it is more of a drug which we know to modulate the pain. So for modulating the pain, maybe a serotonergic drug will be required. So it helps to keep down the pain thing. Now apart from this, we understand that if I go and stimulate the serotonin receptor on the brain vessel, 5-HT receptor, it is also going to cause one thing for me, vasoconstriction. So two things. One, 5-HT receptor stimulation on the brain vessel will cause vasoconstriction. So what was the pain happening due to meningeal irritation? Why did it happen? Due to leakage of plasma. Why did that happen? Due to vasodilatation. So we are trying to inhibit vasodilatation by causing vasoconstriction in the vessel, right? So one problem solved. Second thing that we understand, that serotonin as a substance itself is a part of the pain modulating pathway. So it will also help me out in decreasing the actual pain in the patient, apart from treating the real cause of the disease. Okay, so that's the rule that why we use 5-HT receptor agonist very safely in migraine patients. But that's not very safe drug because there are two groups that we know. One group is a non-selective agents. Okay, the non-selective means that they act on every serotonin receptor. Not only the brain, it acts on the periphery, coronary, everywhere. And we know the name for this one is the argotamine. Argotamine. Or maybe his brother dihydroargotamine. So they are non-selective, but nowadays we are more interested in using the selective agents. The selective agents. In the selective agent, the traditionally used drugs, if you remember, are the 1B and 1D receptor agonist. Okay. The other one is the 1F receptor agonist, the latest one. Under the group of 1B and 1D receptor agonists, we have got with us a lot of drugs with a common surname that are known as the triptans. If you remember the triptans, there are so many of them, like the rizatriptan, the sumatriptan, the zolmitriptan, okay, the elatriptan, the flovatriptan, and naratriptan. So many triptans that I can get, but I'm more interested in using a drug that is the best drug among all. Now, out of all the triptans that we use, you learn details about this, which is oral, which is injectable, which is nasal in format, don't worry. But one thing I want to convey here, that out of all the triptans that I use, the best triptan is the one which is having a maximum Tmax with it. Now what do you mean by the understand the word as Tmax? The drug that stays in the blood for the maximum amount, the timing. It's not the T half that we consider here, we use the word Tmax to explain it. Now the drug which has got the best Tmax out of all that we find is the rizatriptan. So remember this, the best triptan that we find to be useful in migraine patient is rizatriptan. Okay, and some of the authors have written elatriptan also, but in India at least this one is available with us. Okay, now one F receptor agonist is the new drug, yes, that is the DTAN group. In the DTAN that we have got with us is the Lesmidetan. So new drug that is there for treatment of acute attack of migraine, remember, is the Lesmidetan. But remember this, that out of the drugs that we ever use in treatment of migraine, the drug of choice is always going to be a triptan. Okay, and out of all the triptans that we find, the rizatriptan has got the maximum Tmax, and it is considered to be the best triptan out of all. Apart from this, there are drugs available with us somewhere which can inhibit one more symptom of migraine patients, most common, nausea. To treat nausea in our patient, we give a drug which is a dopaminergic antagonist, and we use this drug as metoclopramide. The main reason for this, is that, the nausea as a symptom was due to dopaminergic agonist action. To some extent, there is dopamine agonist action in migraine patients. That's why we use in them to treat nausea is metoclopramide, which is injectable, oral, both way available to us. Okay. Apart from this, there are certain new drugs also with us available. Yes. Under the category of the new drugs, we have got the CGRP antagonist. Since CGRP was the vasoactive peptide that causes vasodilatation, let's inhibit the CGRP receptors. So we have got drugs with us which are known as PANTs. PANTs, yes. The two PANTs that we know is the Ubro and Remi. Okay, I'll just not put the word PANT over there. It's G-PANT, not PANT. It's G-PANT, Ubro and Remi G-PANT. So how do they work? They inhibit the CGRP receptor on the brain vessel. So the vasodilatation thing is again taken care of. How do we treat nausea in migraine patient? By giving a metoclopramide, oral injectable anyway. Okay. So this is regarding the acute attack of migraine. How do we deal with? Apart from this, yes, some people do use it, NSAIDs again. A lot of NSAIDs are there with us, so we can use that also for therapy in migraine acute attack. We can use it, but they are not the drug of choice. So what do we have with us for treatment of migraine? One are the serotonergic agents, okay, in which we find the best and the most reliable are the triptans. Second are the dopaminergic antagonists to treat the nausea part by giving metoclopramide. The third one is the new drug, the CGRP antagonist, the G-PANTs. And the fourth, of course, the old ones, the NSAIDs with us. Okay. So that's about the acute attack of migraine, but most important is to prevent the migraine. By doing what? Prophylaxis. There has been some change regarding the prophylaxis part. In the previous recommendation, they used to say if there are more than 5 attacks in a month, then you go for prophylaxis. But now the changeover is this: if you at all have got 4 or more than 4 attacks in a month, So if 4 attacks in a month of migraine happen, then you go in for prophylaxis. For giving prophylaxis, anytime we can use certain drugs, like the first one that I like to explain here are the beta blockers. Beta blockers are 3, which are PMT. If you remember, propranolol, meta, pro, temo, and all of them have got a common surname that I know as LOL. So I remember when we entered our MBBS, in our time there was no NEET, there was only one exam, PMT. And after giving that exam, our life became nothing but a LOL. Okay. Second one is of course the tricyclic antidepressant that we give, out of which there are so many of them, but we often use amitriptyline most of the time in the patient. Amitriptyline. The third group that we find are the anti-epileptic groups, AEDs. In the AEDs, we have got 2 drugs with us. One is the valproate. The second one that we use is the topiramate. So these are the 2 drugs that we often use for treatment of migraine patients for prophylaxis, the 2 anti-epileptic drugs. Fourth, yes, the calcium channel blocker that we use, that's known as the flunarizine, the cerebroselective calcium channel blocker, flunarizine. Now, is there a drug of choice for prophylaxis? No, it's all individualized. For example, I'll just give you the example, like a female migraine patient comes to me and she has a past history of asthma or COPD something. Like, I don't use a beta blocker ever in it because it might exacerbate the old disease. Or if at all she is a fertile female and she can conceive any time, then don't use a valproate. Okay. If at all she is a migraine patient, completed her family, everything, and she is obese, so give her topiramate, at least that will help her obesity part. So depending on case to case, we decide that which drug to be given in that patient. But remember, the prophylaxis, the therapy has to go in for at least 6 months. So there is no single prophylaxis drug of choice ever in migraine patients. It's all tailor-made depending on the patient's past history, comorbidities, everything. But any patient who gets a migraine attack for more than 4 times in a month requires a prophylaxis therapy. Something new that we should know, that we've been using in the Western countries at least, are the CGRP antibodies. Now they are used not for acute attack, they are used for the prophylaxis part, the CGRP antibodies. Okay, like erinizumab. Like the erinumab. Okay, so erinumab is a perfect example of a CGRP antibodies that we can use for prophylaxis in migraine patients, right? So that's about the migraine patient. And remember that whenever you give a prophylaxis, there's always a lag period. Lag period means it takes time to settle down, like 2 to 12 weeks time is required. So there's always a lag period that we find in migraine patients for the headache to actually not come back again and again, and that's taken somewhere as 2 to 12 weeks most of the time. As far as certain other drugs are concerned, like opioids and all, they are used, but they are used in a specific situation, and that specific situation has got a name as status migrainous. Status migrainous. Now like the status epilepticus, now something that might improve your status is status migrainous. In status migrainous, we find that the headache is persisting beyond 72 hours. So in my patient, if it is persisting beyond 3 days or 72 hours, it is known as status migrainous, right? Yes, in these patients we have a different kind of a treatment that we can offer them. For example, apart from the triptans and everything, for treating these patients we can use a steroid also to decrease the meningeal irritation at least. That's the dexamethasone. Okay. We can also use in them opioids. They can be used in them, and some of the authors have written even the Maxel or the magnesium sulfate therapy for them. So it's anyway very difficult to treat such group of people. They will never have 100% relief in the headache part. So if at all you find these patients, you should do good hydration also. Maybe they are dehydrated for last 72 hours, since they have nausea and all, they don't take in anything orally. And you can give a steroid, you can give an opioid to them, you can give metoclopramide also, you can give a triptan, everything you can try. But few things additional you can use in this patient known as status migrainous. Now moving on to the next headache type that we all should know about, a very famous man, a patient with a cluster of headaches. So that is known as the cluster headache. Cluster headache. Now don't forget this one, because cluster headache is something more frequently seen in males than females. Yes, all headaches are more frequent in females except for the one, cluster headache, that's more frequently seen in males. Now in cluster headache, it is a typical quality of headache that we find in these patients, that is peri and a retro-orbital pain that we feel in them. So these patients are going to have a typical peri and a retro-orbital pain. And don't forget, this typical pain, which is peri and retro-orbital, is for a duration somewhere taken as 15 minutes to 180 minutes. So it's taken from a duration of 15 to 180 minutes, the typical headache. This particular pain is most of the time unilateral, seen on one side only. The third important point is that this particular kind of a headache is often precipitated by consumption of alcohol. So the person takes alcohol, it suddenly starts. And this kind of a headache often awakens the patient from sleep. It often awakens the patient from sleep. So when the person is sleeping, suddenly they're going to get up with headache. That's your cluster headache. And the pain, when I look at the quality, it's often found to be explosive. So it's a very typical explosive unilateral pain felt in the patient. So it's a typical explosive unilateral pain felt by the patient, which is precipitated by alcohol consumption, awakening the patient from sleep. But along with this, remember one thing very typical in these patients is autonomic hyperactivity. Just a second. Okay. So in these patients, the typical thing that we find is a typical autonomic hyperactivity, where my patient will have a lot of lacrimation and rhinorrhea being felt. A lot of lacrimation and rhinorrhea being felt. So there is a lot of redness of the eye, with eye is all the time tearing. There is a lot of stuffiness of the nose and a lot of nasal discharge which is felt by them. Now remember this, that in these patients most of the time they will have headache. Okay, so these patients are going to have headache for a duration somewhere taken as on a daily basis 8 to 10 weeks. So my patient of cluster headache is going to have the headache daily for at least 8 to 10 weeks at a stretch. And now for at least a time gap which I see of 1 year, my patient will not have any headache. it's going to be asymptomatic, and then the whole cycle will repeat in the same way. So what do you find in the patient's life timeline? Like, the headaches for 8 to 10 weeks, 1 year nothing, again headache happens. So attacks happen together. Together, if I keep something, is known as cluster. So the name cluster headache comes from this notion that the attacks happen often in these patients together and together. That's why the name cluster headache is given to them, right? Treatment part, there are a lot of drugs that we've been using for therapy for the acute attack. So remember, for the acute attack of cluster headache, there are a lot of drugs, out of which the first one is your oxygen inhalation. Now the oxygen inhalation that is given to these patients is 100% oxygen at the rate of 10 to 12 liter per minute, a very high flow. But it's not given for a very long time, it's only given for at least 10 to 15 minutes time. And do remember this, whenever you want to treat an acute attack of cluster headache, the best treatment is always considered to be oxygen inhalation. Now how does it work is not clear anywhere in the literature, but some of the authors in functional imaging have found one thing, that in most of the patients with cluster headache that we find, the lesion is somewhere seen in the hypothalamic part. And in these patients we found that there was some kind of hypoxia in the hypothalamic zone. Hypothalamus is happening to regulate two things in me. One is a circadian rhythm and second is autonomic functions also. So why hyperautonomic symptoms like lacrimation and rhinorrhea happens? Because the lesion is in your hypothalamus. Second, why does it occur on the early morning hours, on awakening especially? Again something circadian rhythm, again hypothalamus. So they found in functional imaging maybe there is some hypoxia in this part of the brain. So that was a site of the lesion for this disorder to happen, cluster headache, and you can correct hypoxia anytime by oxygen inhalation. So one treatment, the best treatment anytime considered for acute attack is oxygen inhalation. Apart from this, yes, we have been using the pain modulatory things also, like the sumatriptan, which is injectable subcut. Yes, we give it to the patient, subcutaneous sumatriptan. Apart from this, even the nasal sprays like sumatriptan, zolmitriptan, they have been used in the patient because they are very fastly acting. And one more thing that we have used is the vagus nerve stimulation that might decrease the pain, or the VNS, the vagus nerve stimulation. Okay, so need not go into details of this, just remember a few things on this, that you can give either of the three, but most important and the best treatment for acute attack is always considered to be oxygen inhalation. Now regarding the prophylaxis in your patient of cluster headache, again a lot of drugs have been labeled here, but again remember the first and the most preferred any time is verapamil. Yes, now verapamil is considered to be the drug of choice for prophylaxis of cluster headache any time. Okay, apart from this we have been using other drugs as well, like earlier we used to use lithium also in these patients. We still give steroids to them like prednisone. So prednisone, lithium, verapamil, but remember the drug of choice for prophylaxis of cluster headache is always considered to be verapamil. And don't forget, the prophylaxis is always given lifelong. It's not like 6 months and then you taper and stop it off. No. So in patients of cluster headache, the prophylaxis has to go lifelong. Right. Now, cluster headache comes in a family of headaches, and the family has got a name as trigeminal autonomic cephalgia. Trigeminal autonomic cephalgia. The abbreviated name is TAC. Okay. Now what is there in this TAC? There are three brothers. from the same mother, right? Now the first attack that we have just now seen is our male predominant cluster headache, right? Second one is a unisex headache. That means it happens in males and females both. Okay, so that's the paroxysmal hemicrania. And the third one with a very long name, let's start writing, by tomorrow morning we'll end writing somewhere, that is short lasting unilateral neuralgic or neuralgiform headache with conjunctival tearing. Oh my god. So I can happily abbreviate this whole thing as SUNCT. Short lasting unilateral neuralgiform headache with conjunctival tearing, SUNCT. Okay. Now what are the key things which are similar and what are the things which are dissimilar among them? First of all, cluster headache is more frequent in males than females, one thing. While your paroxysmal hemicrania and SUNCT, both of them have been found to be equally common, almost equally common in males and females. Then most important thing is the frequency. How frequent are they? Like when I look at the cluster headache, the episodes are there, almost 1 to 8 attack in a day. So they are more than 1, but at least less than 8 attack in a day in these patients. While in paroxysmal hemicrania, we find in them most of the time the attack rate is 1 to 20 per day. So most of the time, it's above 5 for them. It's most of the time above 5, but it's less than 20 for them. But still we take it as, okay, I'll put this as 5 to 20. That will be better. Now when we go on to the other side, yes, this time what happens is, it is 5 to 200 per day. So as we go towards the right side, one thing is there that the frequency of attack is exponentially increasing now. Okay. Now how long does the attack happen? Duration part, again very important thing. So when we look into the duration part, I've already told you about cluster headache. The duration is 15 to 180 minutes most of the time. While paroxysmal hemicrania, very important, the duration is 2 to 30 minutes. While the last one, that is your SUNCT, the duration is 5 to 240 seconds. So as you go towards the right, one thing that is going to come down is duration part. That's why the SUNCT, the first line is short lasting. It's for a very short time that we see. Now as far as the symptoms which we consider as autonomic symptom, they are seen with them. So autonomic symptoms like lacrimation, rhinorrhea and all that symptoms which are localized, they are seen in all the three brothers. That's why it's a trigeminal autonomic cephalgia headache with autonomic hyperactivity in that part. Why? Because facial supply, if I look at the facial supply sensory, is from the trigeminal nerve. So there is some activation of the trigeminal nerve, one. There is autonomic symptom and causing a headache, or not exactly a headache, but a perianal retroorbital pain to be more precise. Now apart from this, something confusing now is that the symptoms of migraine, like your photophobia and phonophobia, is also seen in them. So the phobias that we know, the photo and the phono. The photo and the phonophobia is seen in all the three brothers again. Yes, that is very well seen in them. Okay. Then apart from this, few differences are now going to come in. Alcohol trigger. I have explained this also. alcohol trigger is something which is typically seen in patients with cluster headache, not the other two people, not the other two. Now, apart from this, something that we know is a cutaneous trigger, like you touch the face and the pain starts off. Cutaneous trigger. Cutaneous trigger. So remember this, the cutaneous trigger is seen in the last one only, not the first two. So some people will have a very typical cutaneous trigger. So when you touch the face, there is some stimulation of the trigeminal nerve that is going to increase the attack, right? And the last part, of course, the treatment part. Yes, in the treatment of cluster headache, we have seen for an acute attack that we see, yes, for the acute attack that we find, we give oxygen inhalation, the best treatment. For prophylaxis that we have seen, we give verapamil. Now going on to the paroxysmal hemicrania, remember these are patients who are well responsive to one of the drug, that is indomethacin. So one drug that is used in acute attack maybe of paroxysmal hemicrania, easily available and well suited to them, is the indomethacin, right? Okay. As far as the SUNCT, the last one, is concerned, remember for them, maybe for an acute attack, we can use the lignocaine, the lidocaine. So for the acute attack, we can use in them lidocaine, right? And you might wonder, sir, so this lidocaine for these patients, look at the drama now. This is short lasting, 5 seconds, 240 seconds. By the time you realize it's happening and you go and search the drug and load it, it's already gone. So it's just a theoretical thing, not a practical event that we could really follow, because it's very short lasting. But remember, no, at least if I am not treated the acute attack, I should do something to prevent it, right? Prophylaxis. Okay, for prophylaxis in these patients, yes, we can use lamotrigine. So another L now comes in, lamotrigine, for prophylaxis of patients with SUNCT. Okay. So that's about a very small but a very high yielding topic anytime, and most of the questions that we find on this cluster headache especially are one-liners, and they come on this typical table, trigeminal autonomic cephalgia. Don't forget this one, very important, right? So this topic of headache should not be a headache anymore for you. But we know there are various kinds of headache that we suffer ourselves with. There was a migraine patient with a unilateral pain. There's a hypertensive patient, yes, with maybe a back occipital pain. There's a stress related tension headache, band-like, and this is what happens when you start studying. So try to prevent it by studying. The only prophylaxis available for such a kind of study headache is to study. Okay, so the poison is going to kill the poison, right? See you soon.